Good morning, everyone. Welcome to Pediatric Grand Rounds. Uh, the speaker is Dr. Grace Blaylock. She's a native of Roanoke, Virginia, and returned to begin her practice in pediatric orthopedic surgery in September of 2023. So she's been here for an entire year already. After graduation, she completed her internship and residency at George Washington University School of Medicine in Washington, D.C., and continued her training at CHOP. Her clinical interests include hip dysplasia, clubfoot, limb deformity, cerebral palsy, pediatric trauma, and neuromuscular conditions for children. She offers surgical and non-surgical treatments options for a wide range of pediatric orthopedic conditions. Please join me in welcoming Dr. Grace Blaylock.
Hello, thank you for the introduction. So, like Dr. Permer-Schwartz said, I am originally from the area. I grew up in Bogota County. My parents still live here, which was a huge draw for me coming back for when I have children of my own. I was born in Roanoke Memorial. I always joke it's kind of the circle of life for me. I came back here for medical school, and I probably will die in this hospital if I'm being honest. So, no plans to move anytime soon, unless my husband cannot find a job here in 2 years. So, planning to stay for the long haul. So hip dysplasia is one of those topics that I feel great passion about and really enjoy treating patients. So we'll get started. So hip dysplasia, we'll start with infancy and beyond. So I have no disclosures to report other than I love treating babies with hip dysplasia. So a little bit of bias there. Just an overview. So we'll talk about the definition of developmental hip dysplasia. We'll go through the anatomy and development of the hip, all the way back to embryology. We'll talk about imaging evaluation of DDH, the natural history of DDH, treatment options, and then adolescent and young adult hip dysplasia as well. I will not be covering anything related to neuromuscular hip dysplasia in this case, which are pretty different entities. My main objectives for the residents today are to be able to detect hip dysplasia findings on examination. You all are truly the first line of treatment for these babies, so they never make it to my office if it's not detected by the pediatrician. Next is to be able to at least look at and interpret a hip ultrasound or report. To categorize dysplasia based on type and severity, because it is a little bit different based on what the child has. And then to be able to have a basic spiel to kind of what to tell families, because you're the first people telling them what hip dysplasia is, and it can be a very stressful thing. I say it often that I didn't do my hip dysplasia talk right if mom doesn't at least have a few tears at the end of it. Thankfully, hip dysplasia is something that we treat very well in orthopedics, and I've even had our orthopedic joint colleagues say that it's really changed treatment of hip dysplasia in the last 20, 30 years. Has really changed what happens in adulthood because they're not getting those disaster hip replacements that they were having 30 and 40 years ago. So the definitions of hip dysplasia. So dysplasia is inadequate development of either the acetabulum or the femoral head or both. They really go hand in hand with each other. If one isn't developing properly, it does affect the other. What I start by telling families is this is a really broad spectrum of disease. So there's those from having just very mild acetabular dysplasia where we may be a Pavlik harness for just a few weeks, to kids that have full-on dislocations. So a couple definitions. So I would say mild dysplasia would be a shallow acetabulum without any displacement of the femoral head. Subluxation versus dislocation. So subluxation meaning that part of the femoral head is still in contact with the acetabulum where it needs to be. Dislocation where none of the acetabulum has any contact with the femoral head. A teratologic dislocation, which is a hip that was actually dislocated in utero and was never in the socket. The reason this matters is these are usually irreducible hips and often a contraindication to Pavlik harness treatment. While you'll read that a lot of times these are a contraindication, Drs. Lindsay and myself usually do give the kids one shot of treatment to see if it will get the hips back into place. And these are often associated with neuromuscular conditions, things like spina bifida, arthrogryposis, and other genetic conditions. And then later adolescent dysplasia. So we're unsure whether this is something that develops later in life or if they had very mild dysplasia initially and if this was missed or just not able to be detected because the findings were so mild. There are certainly cases where an ultrasound was normal, but then later on in life, kids have dysplasia. So starting with the development of the hip joint, going back to embryology. So the hip develops from mesenchymal stem cells, and this usually starts around the 7th week of gestation. So a lot of times, just when a mother is finding out that she's pregnant. So the cleft is the first thing that develops, and this is the beginning of a femoral head and acetabulum. By the 11th week of gestation, generally the femoral head and acetabulum are fully formed. Obviously, you can imagine very small. This is theoretically the first time that a hip dislocation could occur. So for those teratologic dislocations, this rarely happens. Development continues. As I mentioned earlier, the growth of the femoral head and the acetabulum go hand in hand with each other. And so the growth of the acetabulum is dependent on both the balance of the acetabular and triradiate cartilages. Both of those grow interdependently. So the acetabular cartilage grows through interstitial growth, which means growth from within the cartilage, and the triradiate cartilage tends to expand from appositional growth or growth on the surface. Most kids have a normal hip at birth when the femoral head is seated deeply within the acetabulum and it's held within the confines of surface tension by the synovial fluid. It's actually very difficult to dislocate a baby's hip, even when we're doing our maneuvers in the clinic. You have to give it a pretty good force to feel the true Barlow. When we have a kid that we know has a known subluxation, even when we're in the operating room, a lot of times you can't move it around when they're under general anesthesia until you cut the capsule and that synovial fluid tension is removed. So families are often the one thing that they say to me when kids have hip dysplasia is, how do I hold my baby? I'm so afraid that I'm gonna dislocate their hip. And the truth is, like, it takes a lot of force to dislocate a hip. So gentle handling of a baby is not gonna dislocate their hip. It's not that unstable where it's just sliding in and out. I say that, but some kids that don't have a well-formed acetabulum, can be sliding out a little bit easier. So it just depends on the degree of dysplasia. After growth, and this is the next thing I tell families, is that the growth of the acetabulum and femoral head is interdependent. So what I tell them is this is a lot like modeling clay at this stage. Mostly cartilage. You have the ball, you have the cup, and the growth of both the ball and the cup depends on that relationship. So when we're putting kids into treatment, what we're doing is putting that hip deeper in the socket. And that round stimulus in here encourages that cup to grow around it. So these are, hopefully, will give you a few things to tell families when you start talking. So there was a study that they did in rats, because obviously we can't do this in babies, but what they did was they actually cut out the femoral head. And they saw that in those cases where the femoral head was cut out, the acetabulum never developed. And so this is where they got the concept that the spherical femoral head is most important to predict the development of the acetabulum. As they also mentioned, you have interstitial growth from the acetabular cartilage and the appositional growth from the perichondrium near the triradiate cartilage. As the acetabulum develops as well, you get new periosteal bone formation in the adjacent pelvic bones, so the ilium, the ischium, and the, pubis. So that helps to determine the full shape. The majority of our acetabular shape is determined by the age of 8. So we want to get to these kids as early as we can. For the kids that come to us later, after the age of 8, our surgical options really do change because there's not the flexibility in the pelvis that there was before. Depth is again further enhanced at puberty. And then for acetabular, it's a little bit unclear whether it's instability or primary acetabular dysplasia that comes first. It's really a chicken and the egg situation. So is it that the hip is sliding out and that's why it's not developing normally? Or is the hip sliding out because the cup is not normally shaped? And we actually don't know the answer to that. And they think it could be both. So proximal femoral development. So in an infant, we have 3 primary growth areas, one being the epiphyseal or physeal plate up here. We have our proximal femoral neck isthmus here and our greater troch growth plate over here. Each of these grows interdependent of each other. The proximal end of the femur is primarily composed of cartilage in infants, which is why we start with ultrasounds instead of x-rays. On average, the femoral head ossification center doesn't start to appear until between 4 and 6 months. After a year in practice, I'd argue that's probably even a little bit later. 6 to 9 months is when we really start to see it. I don't start getting any x-rays until 6 months old because it can be very misleading. Even at 6 months old, I've certainly had times where I started with an x-ray for a kid that was referred to me and then I pulled out the ultrasound machine because there was just nothing there to look at. The main thing you can see on x-ray, and we'll talk about that, is just Shenton's line at that point, and that's not always 100% obvious. All right, and so some of the factors that affect growth of the head as well are the pool of the muscles, weight-bearing forces, making sure that someone has normal joint nutrition and circulation, and then their growth plates. So if the epiphyseal plate gets disrupted and the femoral neck and the greater troch keep growing, these kids develop varus hips because of the angles that allow it to keep growing. So they can get abnormal shape at that point. And then once they have a varus or a valgus deformity of their femoral neck, that doesn't usually respond to any treatment other than surgery. And so that's why it's really important that we try to catch these kids early. Weight-bearing forces is really important. So I do have kids that had ultrasounds, were treated in Pavlik harnesses, and then they come back and see us because we follow these kids for several years after they're treated in a harness, and they haven't started walking yet, and their hips look a little bit shallow and undercovered. Oftentimes in those kids, I tell the families that as they start walking, this will help encourage the development of that hip. And so, no, it's not the reason they're not walking yet. Kids with fully dislocated hips can learn to walk normally. Sometimes that's how we detect that a kid has a hip, because they have a limp when they start walking. But weight bearing can make a big difference, and so a lot of times we don't actually interfere with these kids surgically until closer to the age of 3 or 4. So etiology, so some genetic factors that play a role. There are family history. We don't have an identified gene for what causes hip dysplasia, whether it just be the shape that that kid inherits in their acetabulum or the way they're built. But there hasn't been a specific genetic factor identified. However, there have been data that show that if you have a parent and a sibling affected with hip dysplasia, then you have about a 35% risk of having hip dysplasia yourself. And so that is one of our main risk factors for screening kids. So even if a kid has a normal exam, if they have a family member that has a history of hip dysplasia, they should also be screened. And we'll talk about when and where and how to screen these kids. Hormonal changes in late pregnancy can also be a factor. So there's some thought that estrogen causes increased laxity in the hips, which can lead to hip dysplasia or instability type events. In kids that are born premature, there's a lower incidence of hip dysplasia. Some of this is thought to be due to the hormonal changes that occur later in pregnancy. Some of it's just thought to be due to size, because hip dysplasia can also be a packaging disorder. Intrauterine malposition, this is perhaps the biggest risk factor for hip dysplasia. For kids that are breech or low transverse positioning, there's about a 10 to 15% rate of hip dysplasia. So every child in this country that has that risk factor, we usually say into the 3rd trimester. If they're at breech at 20 weeks, we don't usually think of it as being a huge risk factor because they have so much room at that point. But once they get into the 3rd trimester, those kids should be screened. And so when you're taking a history, it's always important to say, were they breech? Because a lot of parents think, well, they weren't born breech, they flipped before, but you need to say, well, how long were they breech? Because if they were breech into the 3rd trimester, then they should be screened. And then postnatal factors. So swaddling has been perhaps the most known postnatal factor that can lead to hip dysplasia. So in cultures where swaddling of infants is more common, these kids do have higher rates of hip dysplasia. In Africa, where a lot of babies are born with the hips in the healthiest position they can, just like the M position that we see in a lot of our baby carriers today, they have almost a non-existent rate of hip dysplasia. So just something to talk to families about. I always refer families to the hip dysplasia website, where they have a whole list of hip healthy products, and including all of the swaddle sacks. But families need to be taught that when you're swaddling, to either not include the legs at all, or make sure those babies have room to flex and extend their hips. All right, so moving on to the proposed pathogenesis. So it's thought that there's excessive capsular laxity in a shallow acetabulum. With that excessive capsular laxity comes loss of surface tension on the femoral head by the synovium fluid in the joint capsule. As we talked about earlier, that synovial fluid force and surface tension is what keeps that hip located. So if you get a redundant capsule, that causes loss of tension of the femoral head, and that can cause migration of the proximal femur. Then that migration of the proximal femur leads to the lack of the spherical head within the acetabulum, which then leads to further maldevelopment and propagation of this. So the main changes that we see that are associated with hip dysplasia, and these become important when we talk about surgical release of hip dysplasia or the blocks to reduction. First is an enlarged acetabular labrum, so they can get the limbus is really like a thickening or an inverted labrum. So you hear the labrum can block it or the limbus. They're really kind of same thing, basically. They can get a flattened acetabulum, like we talked about. As that capsule expands, it causes the ligamentum teres to also lengthen, which can then become a block to reduction. Down in the bottom of the acetabulum is a transverse acetabular ligament. When the head is not sitting there pushing the hip down, that transverse acetabular ligament can fold into the joint and become a block to reduction. As I mentioned, the hip capsule becomes expanded. As that's redundant, it can cause a block if you're trying to move that hip back in. And then things like the iliopsoas tendon that are crossing the hip joint can also become contracted and become a block to reduction. And so when we get to surgery, these are all things that we're looking for and making sure we release if we do end up at that point. So epidemiology, if you look at instability events or hip dysplasia, about 1 in 100 births has some evidence of instability on examination. Only about 1 in 1,000 are actually true congenital hip dislocations. One of the things I tell families is that 1 in 100 babies has hip dysplasia, and only about 1% of those ever ends up needing a surgery from their hip dysplasia. So that's one thing that I think can reassure parents that yes, we have hip dysplasia. It's pretty common, 1%. There's a lot of babies being born, so I see 5 or 6 kids almost every day in my clinic for hip dysplasia, but only 1% of those ever end up needing a surgery from it. So I can say that in a year, I've only done 1 hip dysplasia case. It's supposed to be 2, but unfortunately she got strep throat last week, so we'll reschedule that one. When you're thinking about risk factors, we think about the Fs. So frank breech, I know that term's probably used a little bit less, but just for the F standpoint, frank breech, being firstborn, that's thought to be just because the uterus has never expanded, so it's tighter. It's more of the packaging. Female sex in a 6-to-1 ratio. That is thought to be related to the fact that more estrogen tends to cross mom's placenta in kids than in females. I mentioned the family history, so 6% of kids that have hip dysplasia have an affected sibling. Of those, 6% have a sibling that's affected. If one of your parents has hip dysplasia, you have a 12% rate. And if you have a parent and a sibling, that's when it goes up to that 36% rate of hip dysplasia. So really important to ask. Now, most people have trouble saying if there's a family history. And so what I'll ask about is, was anyone ever treated in a brace as a baby for any reason? A lot of times they'll think of clubfoot in that case, but it gets them thinking about, was anyone ever see any pictures of a kid in a brace? Did anyone have a hip replacement at a very young age? So not like 60s, 70s, but someone in their 20s or 30s that needed a hip replacement. And sometimes people can then say, oh yeah, we had this person or someone had this, and then we at least know we should screen them. In my mind, if there's any question to you as the pediatrician, if there's a risk factor, it's worth a screening. They've shown that in other countries, there's universal screening, especially in Europe. That hasn't been shown to be cost effective in this country, so we rely heavily on our exam and our risk factors to help us determine who to screen. Fluid abnormalities, so having low amniotic fluid levels is a risk factor. Having a foot deformity, so things like clubfoot, metatarsus adductus, calcaneovalgus, all things that are suggestive of a packaging disorder. And then facial asymmetry, which in this case would be like a torticollis. So metatarsus adductus we mentioned, so curvature of the foot inwards. A calcaneovalgus, so technically a flexible thing that resolves on its own, a physiologic foot malposition, but when that kid comes out and the dorsum of the foot is resting on the anterior tibia, that's a reason potentially to screen. Torticollis, congenital knee dislocations, and again, oligohydramnios. Any of those things should prompt a screening, even if it's just an exam. All right, so talking about screening. So most important, the first step of our screening is physical exam. I will say with 1,000% that you all are excellent at screening hips. The number of hips that are detected in the hospital of this institution is very impressive. I have a partner, or a fellowship colleague, who is now out in Wisconsin, and she has so many kids coming in that are 2 years old and they have hip dysplasia, dislocated hips that weren't caught as infants. And so kudos to you all, because it's not always easy to feel those subtle instabilities, and I feel like you all are excellent at it. We should have, so we'll talk about the Barlow, the Ortolani, and the Galeazzi testing. Repetitive screening until walking age. So until they're walking, we should be checking their hips every time they come in for a pediatrics visit. Ultrasound recommendations. So the AAP recommends an ultrasound study at 6 weeks in high-risk patients, regardless of exam findings. And we'll talk, but 6 weeks is really important because all of our data for hip dysplasia is based on a 6-week-old infant. So when we get those ultrasounds at 3 and 4 weeks, the data doesn't really tell us a lot because sometimes it's just hip immaturity rather than true hip dysplasia, and then the kids are going to need additional screening. They get referred to us, which is fine, and then we end up doing an additional ultrasound in the clinic. But for families where cost is a factor, if we can minimize how many ultrasounds we're doing for them, I would wait until 6 weeks old. And then any kid that has positive exam findings should get a screening. So physical exam, the Barlow dislocates a dislocatable hip. So they call it the click of exit. I prefer the term click clunk rather than click because clicks are benign soft tissue, clunks is actually movement of the joint itself. So Barlow would be, oh, I guess I put both of these ortholani. So Barlow is here, where you're adducting the legs, so bringing the knee inwards towards the body and giving a posterior directed force. And so sometimes there is just a little subtle instability. So laxity versus a true Barlow. So a Barlow actually dislocates the hip or makes it subluxed enough that you feel that clunk. A instability, you might feel a little bit of a shift. Either way, if you feel something that feels abnormal to you, I think it prompts a screening. An ortholani takes a dislocated hip and reduces it. So ortholani is much easier to feel in a young newborn infant or a few-week-old infant before the soft tissues become contracted, because after that point, it can be really hard to reduce a dislocated hip. And then the Galeazzi test is the apparent limb length discrepancy due to a unilaterally dislocated hip. So if a kid has bilateral hip dislocations, the Galeazzi can fool you because they can still look equal. So after 3 months to a year, things do change. The Barlow, the ortholani become much more difficult because of those soft tissue contractures that develop. So perhaps the most sensitive test at this time is limitations in hip abduction. Most kids have between 60 and 80 degrees of hip abduction at this age. And so if you have either asymmetry in your abduction or both sides limited, that should prompt an ultrasound. Again, we can look at leg length discrepancy or the Galeazzi test because that stays present even at older age. And then the Klissick test. So what the Klissick test does is you take your middle finger and you put that on the greater trochanter. You can see here, and then you take your index finger and put it on the ASIS. So the ASIS is the bony bump that we all feel in the front of our pelvis. When you have those two fingers, and kids are small enough at this age that even if you have small hands, it should not fool you. If you were to draw an imaginary line from between those two fingers, it should point directly to the umbilicus. If they have a dislocated hip, that means that the greater troch is going to be higher. And so when you have your hands on the ASIS and the greater trochanter, it's going to point between the pubis and the umbilicus. So another test, most of us don't use it often, but if I am a little confused or on exam I don't have anything that I can feel, I will use that test. Also very important with hip dysplasia exams is babies should be undressed for this exam. Leaving pants on, no. I usually take off the diaper to look at their legs first and then obviously put the diaper back on so a little boy doesn't pee on me as I'm doing the test because those are sneaky little guys. But make sure that you can fully see the legs because pants can limit abduction if they're too tight and you can't really see everything that you need to see. Most parents expect the kids to be in the diaper when they're examined. In kids greater than 1 year old or walking children, pelvic obliquity is one of the things that you can see. They also can get a lumbar lordosis that is more than normal because as their iliopsoas and muscles tighten, it pulls that spine into a lordosis. They can get a Trendelenburg gait, which is just from the weakness of the abductors because the tension is affected when the hip is dislocated. And so with a Trendelenburg, if my left hip is dislocated, I'm going to dip on my left side as I put weight there. So that's what the Trendelenburg looks like. For toe walking, so this is usually more present in a one-sided dislocation, and they're making up for that inherent limb length discrepancy by going onto toes on one side. Lots of kids get excited and go onto their toes between the ages of 1 and 4, but if it's consistently one side that you're noticing, or the parents are noticing, that should prompt screening of the hips as well. And then again, they'll still have that limited abduction at that age. Other reason, just while we're here, the other reason that kids tend to go on their toes before they're really walking is that when they go onto their tiptoes, it locks the ankle joint or the subtalar joint and helps them stabilize, which is why kids that aren't quite ready to walk, when they're standing or cruising around, they often go up onto their tiptoes because it gives them that added stability that they need. So other possible findings, and perhaps some of the more common reasons for referral to us, are thigh crease asymmetry and clicks versus clunks. So some babies just click a lot. Oftentimes they have knee clicks as well. So I've had some referrals for hip clicks, and when I'm actually feeling their hips, I can't get the hip to click, but I feel their knee clicking under my hand. Regardless, if you feel a click, I think it's reasonable to get an ultrasound because it's a fairly benign test, and the risk of missing a hip dislocation or dysplasia can be a big deal for kids later. Again, the thigh crease asymmetry, so I look at them from both the front and the back with the diaper off. And what can happen is when a hip is dislocated, it changes the tension on the soft tissues, and that's what can lead to that thigh crease asymmetry. All right, so moving on to imaging. So when and what to get. So when to get. So If a patient has a positive exam or congenital abnormality, it is appropriate to get this immediately in the newborn nursery or while inpatient. Our pediatric PTs are excellent at putting on Pavlik harnesses. So if you have a kid in the hospital that you're concerned about, order the ultrasound, put in the physical therapy consult, they'll come look at them, they'll put them in the Pavlik harness. Dr. Zielinski and I are usually available. If you send us a message, say we have this kid, do you mind taking a look at their imaging if you're unsure what to do? We'll usually review it, we'll put a note in saying we didn't examine the patient ourselves unless we're in the hospital that day, but we recommend this, and the pediatric PT team will be placing a Pavlik harness. We had a week where there was 3 babies born with hip dislocations. They were all out, they all actually know each other because they were all out in the hallways crying together. And the families actually come almost the same week to see me. But all 3 of them were caught in the hospital, and all 3 of them, by the time they got to me in clinic, had stable hip joints 2 weeks later. So it's really important and really great that those were caught early, because sometimes if a hip leg remains dislocated for too long, I can't get it to go back in with the brace. So when to get delayed. So if someone has a normal exam with the risk factors, so that breach or family history, any other risk factors that we talked about, like packaging disorders, at 6 weeks old would be my preference for when you all obtained the ultrasound. So what to get? If they're less than 6 months old, when you think that you need to get an image, I would recommend starting with a dynamic hip ultrasound. It's important that it's a dynamic, so when the sonographer is giving or performing the exam, they are giving those dynamic stresses to see if there's instability of the hip as well as just the dysplasia. Here in the report, they can be a little confusing. They call things subluxation that are really more under coverage than subluxation. Subluxation means that when they push, it's actually moving out of the socket. Under coverage is more just a shallow socket that the head's not fully seated. But regardless, they're both dysplastic findings and prompt referral to orthopedics. If you run into the issue of it's going to be 6 weeks before we can get an ultrasound, which happens fairly frequently, we are always happy for you to reach out to us. And if we say we'll try to squeeze them in, we almost always have slots held that we can get our hip dysplasia kids in. And then Dr. Zielinski and I both perform ultrasounds ourselves in clinic. So if that seems to be the rate limiting step, where especially if you're really concerned about a positive exam finding, then send them to us. We'll get the ultrasounds ourselves in clinic. And then if they're greater than 6 months old, then starting with an AP pelvis radiograph. If you can't see the ossific nucleus, that's when I would recommend getting the ultrasound. All right, so looking at a hip ultrasound. So I go over these with families each time they come to clinic. So this right here is our iliac bone, what we all think of as our hip bone up on the side of our hip. This little triangle is the labrum. Here is our femoral head with the beginning of an ossific nucleus here. This bone is the greater trochanter, so bone shows up white on x-ray and then has a shadow behind it usually. Here is the beginning of the cartilage of our acetabulum, and then our triradiate cartilage down here. And then our glute muscle tendons coming up and above. So a few things that we look at, perhaps the most important is the alpha angle. So alpha angle is the angle that is formed between the ilium and our acetabulum here. We want that to be greater than 60 degrees by the time the kid is 6 weeks old. My usual rule for whether something is immature versus dysplastic is based on whether they're 10% off of normal. So if I have if someone got an ultrasound when they were 3 weeks old and they end up in my clinic before 6 weeks old, if it is within 10 degrees of normal, I will usually wait and say, come back and see me in 3 or 4 weeks, we'll repeat the ultrasound. And if at that time it's abnormal, then we'll start a brace. Most families tend to be receptive to that because most of them want to avoid the brace at all costs if possible. And then the beta angle we use a little bit less, but you want the beta angle to be less than 60. Coverage is the other thing. So this is what I was talking about, subluxation versus under coverage. So coverage is determined by how much of the ball is below if you imagine a horizon line going this way, you want the sun or the femoral head to be 50% below that horizon. And so that's this area here. And then we want 50% of the ball to be below it. So anything less than 50% would be considered dysplastic. So you can have a completely normal alpha angle and still have a dysplastic hip if that head is not covered appropriately. This is the graph classification. I do not use this at all in my practice, but it is out there. You may hear about it. Basically, it increases in severity from normal to a dislocated hip. Graph is one of the main names in hip dysplasia. But I don't use this at all in my practice, but you might get tested on it at some point. Talking about severity, so families often ask, like, how severe is this hip dysplasia? Because they want to be told that it's not very severe. So mild hip dysplasia, I would consider either a clinical feeling of laxity with a normal alpha angle or an alpha angle less than 60 degrees. It jumps to moderate if the hip is subluxable, or if the alpha angle is less than 50 degrees or there's less than 50% coverage. And then severe would be an alpha angle of less than 45 if the hip is dislocated or if there's minimal coverage, kind of like the example here. So when I look at this, I can see there's not a nice sharp angle here between the ilium and the acetabulum. And then again, you only see about a third of this ball below the hip, or below the horizon, suggested that there's severe undercoverage of the hip. Moving on to x-ray. So there's a few things that we look at on x-ray to help us determine whether or not a kid has dysplasia. So one of those is draw a Perkins line, which is a vertical line down from the side of the acetabulum. This helps us determine coverage and is very useful in older children. So we want 10% or less of that ball to be outside this horizontal line. Anything greater than that would be considered some dysplasia. And then if you were to take Hilgren liners and Perkins line and put them side by side, you want that femoral head, I don't know if I have a picture. Yep. You want this femoral head to be mostly in this area here, suggested that it's in the correct position. So Schitten's line is an imaginary radiographic marker that is running up the femoral neck isthmus and going around to the inferior pubis here. You want that to be a nice smooth arc. This is a very obvious example, but here you can see that the hip is completely dislocated. There are cases where it is very, very mild. Our radiologists do like to comment on Schitten's lines in almost all their reports. Half the time I agree with them, half the time I don't. So I kind of use that feedback and the other markers for dysplasia to determine whether I think it's truly dysplastic. But Schitten's line, it can be very subtle. There's actually a tool on our no read where you can draw like an arc. And so I often will draw that in clinic to see if I can tell if there's any break there. Next, and probably the most important to me, is the acetabular index, which is formed between Hilgren liner's line and then running up the acetabulum. If you read the notes that I put in after I see one of the kids, we want at 6 months old for the acetabular index to be less than 30 degrees. If it's 24 or less at 6 months old, I say the hip looks normal, I don't need to see the kid back. The gray zone is between 25 and 30. So between 25 and 30, I recommend repeat screening. So if you're concerned or don't know, or if you get an x-ray read and you're like, the acetabular index is 27 and the kid is 6 months old, it's normal, yes, but that means that kid should continue to be watched. So either refer them to us, we're happy to look at them, or get another x-ray in about 6 months. The goal is that by the age of 2, so 24 months, it should be 24. And so that's what we're watching. If it is greater than 30 degrees, that's when we start treatment in a harness, or in this case, it'd be a rhino brace at that age. All right, so the natural history of GVH. So Barlow did a study, this is back in 1962, where they found that 1 of 60 infants has hip instability in one or both hips. We've kind of moved that number to 1 of 100. But really important in his study is that they found that 60% of those hips stabilized within the first week of life, and that 88% stabilized during the first 2 months without treatment, which is why we don't recommend actually treating hip dysplasia for mild dysplasia until about 6 weeks old, because a lot of those ultrasounds, if we get it at 3 weeks old, by the time they see me at 6 or 8 weeks, they actually look normal. In those kids, I kind of talk to the parents about it. Oftentimes, I still do get an x-ray at 6 or 7 months old, because if there was any concern that they had hip dysplasia at some point, I don't want to miss it later on. So one x-ray, yes, it is radiation, but it's like essentially equivalent of a plane ride. And so I think that in those cases where you're unsure, it's send us a message, send them to us, or get an x-ray when they're 6 months old. Only about 12% of the infants in his study had true congenital dislocations and persisted if they didn't have treatment. Another study by Coleman in 1968 had 23 patients that were untreated. 26% of those were dislocated, 13% subluxated, and 39% had retained dysplastic features if they went without treatment. Only 22% of those actually normalized. Another study by Pratt in 1982 looked at dysplastic hips, and they found that they were followed by that were not treated. They followed these kids for 11 years, and they found 15 of them were actually normal at end of skeletal maturity. And so what this evidence and data tells us is we actually have no idea what's going to happen. And so we're unable to predict the outcome of unstable hips in newborns, which is why all kids that have hip instability should be treated with a harness. And so we also don't know, even after treatment, what happens with a lot of these kids. And so for kids that have hip dysplasia that is stable, so stable dysplasia meaning no Barlow, no Ortolani, although I tend to lean Barlow being more of a stable finding than unstable finding. I follow those kids till at least the age of 2. And sometimes if I have any concerns at all, I'll follow them closer to the age of 5. For kids that have unstable hips, I follow them until skeletal maturity. And I say I follow them until skeletal maturity. That's my plan as I've been in practice for 1 year. So treatment options, starting with cute babies and Pavlik harnesses. Really important, and this is the first and most important treatment option that we have for kids with Pavlik harnesses. There are other options, but this is definitely the gold standard here in the United States. So kids that have or from birth to 6 months, this is the first treatment option. And even, it says reducible hip, but even kids that have a dislocation, if it's an Ortolani positive, we will try to put that hip back into place with the harness. We do abandon the harness if after 4 weeks the hip is not reduced. There are things such as Pavlik disease where the hip is stuck in that position and sitting on the femoral head, but they can make changes to the femoral head. Femoral nerve palsy is perhaps the most important thing to warn families about when I put them in a harness. Every baby that I treat has my email for direct access. Some families use it a lot, some don't use it at all. But I want to know if a kid develops a femoral nerve palsy because that harness needs to be discontinued immediately for that nerve to recover. I usually will give them 1 chance after the harness. I give them about a week break, putting them back in it. If it develops again, the harness, we have to switch to a different option. And that's when some other braces, like the Tubigen, which is basically a little cup-shaped harness. I don't think I included a picture. Has little cups that their legs go in and these beads. It almost looks like IKEA made it. I think it is a Swedish product, but lots of beads that go up and around. It's not as comfortable, but for kids that have a femoral nerve palsy that can't be treated in the regular Pavlik or are being treated for clubfoot and have to be casted at the same time, that's our first line of treatment for that. So how often are these kids in the harness? So if they have a stable hip, they are in the harness 23 hours per day. They get 1 hour out of the harness. If they have an unstable hip, it is 24 hours per day, directly on the skin, cannot be removed for bathing or anything. And so in those cases, the harness, onesies can go over the harness, nothing over the legs. And it's really important, it seems silly, but even that hour a day can make a huge difference. We want to flex the hips up to about 90 degrees. What I tell families, so this kid in the bottom right is the perfect example of how a Pavlik should look. He's abducted about 45, 50 degrees, and his hips are flexed about 90 degrees. Now, all of these, you can see the hips are way higher. If the baby brings the hips higher, that is okay if they do that on their own. I just want to make sure that I'm not putting their hips in that position. So I always check when I'm marking their harness that when I pull their legs down to the resting position, that it's at 90-degree angle. And then we see these kids back about every 3 to 4 weeks for repeat ultrasounds. Next is the rhino brace. I just love this little picture. This kitty's so cute. This is something that we consider if Pavlik harness fails. The problem with this harness is it can't be really used for unstable dysplasia because it has to be removed for diaper changes. So for unstable dysplasia, there is a brace that if you don't see it frequently, but I do use it, it's called the Ilfeld, which has metal cups around the legs. The difference is it doesn't have this area here, and so the diaper is fully free, so kids can use that. They're not as common, we don't stock them here, so we have to order them. More commonly, what I use the rhino brace for is for residual dysplasia after being treated in a harness, or a kid that's about a walking age or 6 months old and still has signs of uncoverage or a shallow acetabulum. I put them in this at nighttime only, and the thought is that it can help the 12 hours a day. The rule is if they're in their crib, they need to have it on, so nights and nap time, so it's part of the routine. By 18 months old, kids are way too smart. You'll walk into the room and this will be off. That's what I tell families. As soon as they start taking it off consistently, we stop it. But as long as they're tolerating it, we should continue to wear it. Next is closed reduction and spica casting. So technically operative, but sort of non-operative. This is usually indicated in babies from 6 to 18 months old who have failed Pavlik treatment. So we'll attempt a closed reduction under general anesthetic when their muscles are nice and relaxed for us, and basically give an Ortolani maneuver to the hip and then put them into the spica cast. Oftentimes, if you cannot see the ossific nucleus, we'll do an arthrogram to confirm that it's reduced. If we feel like the unstable, so we talk about unstable zones. So if the hip has to be really widely abducted in order to keep it maintained, then we'll often do an adductor tenotomy at the same time to release some of that tension. So we don't have to put them in such an abducted position, because greater than 60 degrees of abduction can cause some stress on that femoral head and can lead to some changes. I haven't never seen that, but it can happen. So we will do an adductor tenotomy at the same time, and then we'll confirm our reduction with a CT or an MRI postoperatively. At this hospital, I found it's very difficult to get an MRI in the hospital because the baby has to remain sedated. And so oftentimes a CT is the method of choice, just because we can do it quickly, because they scream and cry, and if they move too much, the MRI doesn't do us any good. Sankar et al. I will tell you that I'm a little bit biased in all of my training, because Sankar is at CHOP where I trained. So basically everything I do is what he trained me to do. He does have some different opinions than other people in the pediatric hip world. But he has a very high success rate of initial close reduction. About 91% of those kids have successful initial close reduction. But you cannot ignore the fact that 25% of those hips develop AVN. That's a very high number. So some people, especially if you trained up in Canada at sick kids, they do not do close reductions at all there. They wait till all kids are 18 months old, and they'll do an open reduction and a pelvic osteotomy at the same time. So Dr. Apel, who works here, whenever we talk to him about hips, he's like, oh, we don't do close reductions, the AVN rate is too high. But Dr. Sankar has a very low tolerance for, if he feels at all, and this is one of the hardest parts of training with him, is that when you put the hip back into place, he's like, oh, too much tension. And you're like, what do you mean? Like, he's like, it's just a feel thing. And you're like, okay, great. So I guess I'll figure it out at some point. But if it felt at all like there was too much tension, that's when he feels the AVN rate goes up. And so that's why he does many more open reductions than closed reductions. I think I did one closed reduction in my year of training with him, and we probably did, as a group, I think probably 50 open reductions. So pretty low that he does that, but you see that when he looked at the hips, a lot of them had AVN, which is probably why he has gone away from doing closed reductions. Here's your arthrogram. So what we see in the hip, at this stage, you can't even see an ossific nucleus, but once you put the arthrogram dye into the hip, it coats that cartilage and gives us a nice idea of where the hip is located. So next this is outlining some of the blocks to reduction. So this is showing the transverse acetabular ligament is outlining there. Here, and what you'll hear about is the medial dye pooling. So if you see this medial dye pooling, that hip looks like it's reduced, but it's not seated well enough in the socket. So something is in there that's preventing the hip from seating. If the hip seats, you really shouldn't see any dye pooling in that area. And so this, if I saw this in the operating room, I would likely switch to an open reduction. Now, I personally don't like to take kids for a closed reduction until they're at least 9 months old, and the reason is that I want to be able to go ahead and do the open reduction if I have to while I'm there to save an anesthetic. So even if I have a kid that is 6 months old and has a dislocation, I will leave it out for 3 months before, because they're just too small to do the open reductions when they're 6 months old. Even 9 months is probably pushing it a little bit. Moving on to operative, so you can see as increasing age and increasing deformity, it changes what we need to do surgically. So closed reduction, usually until about 12 months old, is the mainstay for a lot of people. After that, you move on to open reductions and soft tissue releases. That's that adductor tenotomy. When you do an open reduction, we also release the psoas tendon. We can clear out all of those blocks to reduction that we talked about. We cut out the acetabular, we cut the acetabular ligament, we cut out the ligamentum teres, and then we do a capsulorrhaphy to help tighten up that capsule that has become expanded afterwards. After 18 months old, a lot of times, if the hip has not been located before that point, they also have pretty significant acetabular dysplasia and require a pelvic osteotomy as well. And then femoral osteotomies tend to be more common the older you get, because if the hip's been dislocated for 3 years, usually the tension on the soft tissues is such that if you go to put the hip back in, either it won't go, or the tension is so high that you worry about the AVN rates, and so sometimes we'll do a femoral shortening osteotomy at the same time. So briefly, I know that you guys are not surgeons, but just so you have an idea of what we're doing to your patients. Open reduction, this is a medial open reduction, which is not the way I usually do mine. I usually do anterior. So if one of the kids that I operate on for you, you'll see that they have an incision kind of up from their ilium down to in front of their hip here, below the ASIS. Medial reductions are more common in younger patients, below the age of 12 months. But again, I'm just biased by where I trained, so I actually didn't do any medial open reductions, and so I don't know actually how to do it. So I would do all of mine anteriorly. And then, like I said, we'll do the adductor and the psoas release at the same time. Kids that get an open reduction are then in a spica cast for 6 weeks. And then after that, they come out of the spica cast and go into a brace at nights and nap time. So femoral osteotomies, this, I said I wasn't going to talk about DDH. This hip is actually, or neuromuscular. This is a crazy hip. These are both dislocated, and you can see that the acetabulums are almost not visible. They're so steep. And so in this case, they did a femoral osteotomy. It looks like they both did varus, where they cut and then angled the hip down, in addition to shortening. Like I said, this might facilitate the reduction and help to decrease the risk of AVN. Briefly, pelvic osteotomies. There are lots of different pelvic osteotomies out there. Most commonly, the ones that you'll see here are the Salter and the Dega. A Salter osteotomy is a complete cut of the pelvis right here. In those cases, we do have to put pins into the hip to hold that in place as it's remodeling. Those pins will come out when the child is a year old. And then the Dega, you don't go all the way through to the sciatic notch. You just stop shy of it. And it's more of a hinge. And then you put some bone graft in here to hold that open. It does not require internal fixation. The decision to do a Salter versus a Dega osteotomy is based on the shape of the hip. So if the hip looks like it has a very short acetabulum, then it's not going to hinge enough to cover the hip. In that case, we'll do a redirectional or a Salter osteotomy to help cover that hip. And if it seems like the hip is long enough, it's just steep, then we'll angle it down with the Dega osteotomy. Dega osteotomies are also more common in kids with neuromuscular hips. So those are probably the two most common that we see. Some of the others are more salvage or for older children. So like I mentioned earlier, stable versus unstable dysplasia, it's important to know the difference between these two to figure out how long to follow these kids. We then tend to follow the stable kids for about somewhere between 2 and 5 years, depending on the degree of dysplasia that they had, and the unstables will follow, even if it's only every few years until skeletal maturity. They did a study in JPO where they looked at 74 dislocated hips that were successfully treated in the pelvic harness. So never required a closed reduction, never required any other surgery. They were normal at 3 to 5 year follow-up, but then at the 10 to 16 year follow-up, 17% had radiographic evidence of dysplasia, which is why we followed those kids longer. Now, doesn't matter, they were asymptomatic. So maybe it doesn't matter, but I think it's important to educate these kids, even when they're teenagers, to say, hey, you have this is still there, and there's a very high chance you're gonna need a hip replacement at some point in your life. Just so because all of this that they are being treated with as infants, they're not gonna remember when they're older. Which is the other way I try to help parents who are very upset about the pelvic harness, that this is all gonna be a distant memory. Most moms want to burn the harness when they're done with it. So moving quickly to dysplasia in the young adult, this is unclear whether it's an untreated or residual dysplasia from childhood, or is it dysplasia that arises later in life, and can also develop after things like Skiffy or Perthes disease. Main things for this, they have groin pain, sometimes can have a Trendelenburg or a limp, may have a remote history of trauma or overexertion, but most of the time kids with dysplasia, it's not really trauma that's the problem. It's more they're like dancers or something where they're overusing their hips and tend to have problems. Usually hip flexion and external rotation and weight bearing or for a long time in a single position can exacerbate their hips. And then a lot of times they also have hip flexor iliopsoas irritability. Physical exam for these kids is a little bit different. One, you want to see if they're hypermobile. So we're showing Baden signs over here on the right. We'll look at their gait, determine whether they have any abductor strength issues, any range of motion limitations, whether they have impingement signs, so things that are like flexion, adduction, internal rotation, or flexion, abduction, external rotation, which are impingement signs. Anterior apprehension is giving a anteriorly directed force. These kids kind of feel unstable, like they feel like they're going to pop out. And then you do the prone external rotation test, which is also can cause them feelings of anterior instability. First treatment option for kids at this age with hip dysplasia is physical therapy. We want to try to control their pain as much as we can because the treatment options for this age are much bigger deal surgically. And we'll talk very briefly about that and we'll wrap up. So for kids that have acetabular deformity and adolescent dysplasia, they usually have a long acetabulum that is very shallow. So you'll see the femoral head is very uncovered. Usually they have actual acetabular insufficiency, which is usually anterior and laterally for most of these kids, which is why that anterior apprehension occurs. They may have retroversion, which this is demonstrating retroversion here. So this is a crossover sign where the wall, anterior and posterior wall of the acetabulum are crossing over each other. You also can see the ischial spine is here, and you should not be able to see the ischial spine on an AP pelvis. And then they have a lateralized center of rotation, meaning that the hip is outside, the center of rotation is outside of under the acetabulum. They also may develop femoral deformities where they have small aspherical heads, a valgus neck, and increased aneurysm. Some of them also develop a cam deformity, which is illustrated here, where they have an extra bump and it causes that impingement. They also have issues with their soft tissues, such as thickened joint capsules, contracted muscles, like they often have significant hamstring and iliopsoas tightness, and they might have a shortened sciatic nerve as well, and so they often have, they can get radicular type pains. Imaging, starting with x-rays at this age. Most of these kids, if they have hip pain, if you get an AP pelvis and you don't see anything, but there's persistent pain after therapy, then send them to us, we'll get the advanced imaging. But they usually would get a frog leg and a 45-degree done in a false profile view, which I'll show you. I wouldn't order a CT or an MRI until I had them try physical therapy first. And here's some illustrating some of those images that we get. And this is showing the under coverage of the femoral head. So management, as I mentioned, and physical therapy being the main thing, we will occasionally try steroid injections in our teenage patients. And then surgically, looking at hip scopes or significant pelvic osteotomies or femoral osteotomies, which can be massive undertakings. So arthroscopy usually is for kids with impingement. Most of that is due to the instability type thing, so they can get labral damage, which is why they require surgery for that. And then if there's that extra cam bone or abnormal shape to that acetabulum, sometimes that can be addressed with a hip scope. This is Dr. Gans. He is the one who developed the periacetabular osteotomy. Because you're not surgeons, we'll move quickly through this, but basically what they do in this surgery is they take the acetabulum and completely detach it from the remaining pelvis and then stabilize it with screws. This is the one surgery I say I would never have. So hip replacements are too good, but some kids, they are 20 years old and they have such excruciating pain that it's limiting their daily activities, and this is where they end up. So if you have a teenager that ends up being referred to us, Dr. Zielinski and I do not do this procedure, but our surgeon, Dr. Koobs, does. They're not super common. They're probably one of the biggest procedures that I've seen in orthopedics, other than a spine fusion. And I don't know that they ever have a normal hip even after this surgery. So, key points. You are the first line for these babies, so your exam matters. We are very lucky here in Roanoke that we have excellent pediatricians who are catching hip dysplasia in newborns. And we get to have the easier part of that job because we're not having those hard conversations at 6 months old that these hips are dislocated and now we need to do surgery. So keep doing what you're doing. Whatever you all are doing, your training is working. Next, all babies with an abnormal exam should get an immediate ultrasound. Babies with a normal exam and risk factors should get an ultrasound at 6 weeks old. Any breech baby, even if they had a normal ultrasound at 6 weeks old, should get an AP pelvis at 6 months old. That's probably the one thing that we don't do as often around here. But if you don't refer them to initially, if you have questions, send us a message on my chart. We're on Epic. We're happy to get back to you and say, hey, yeah, we don't need to see them now, but get an X-ray at 6 months. If that looks abnormal, send them our way. And then most important thing to get these kids' hips to stabilize is compliance with bracing. So if you see a family and you're like, wait, you're supposed to be in a hip pelvic, and you're not, ask them about it. Let us know so we can talk to the families. Thank you. And these are my pride and joy. Questions?
With regards to femoral nerve palsy,
Yes.
how do you detect? How does a parent detect that?
Good question.
Lack of movement, and if so, if they're in a harness all the time, how do they see lack of movement?
So babies in hip harness, pelvic harnesses can kick their knees still. And so knee extension is controlled by the femoral nerve. And so I tell the family, if you've gone more than like an hour and you haven't seen your kid kicking their leg, take off the harness, send me an email, I'll see you the next day. I'd rather them be out of the harness, even if they have a dislocated hip, than develop a femoral nerve palsy. Because if it doesn't wake up, then it doesn't matter if your hip's dislocated. But yes, it's kicking of the legs, which babies can still do in pelvic harnesses. Yes?
we get some like questions, as you alluded to, some reads on radiology that are like, I don't know what to do with this. This didn't give me anything to like say, you know, hey, this is abnormal definitively. Do you guys, this is just like workflow question. Do you prefer looking at it just like, hey, can you check out this x-ray in Epic? Or would you guys rather just see them in clinic? And that's kind of.
I'd rather check out the x-ray. We have a very full schedule. So,
that's what, yeah, so that's what I wondered. Okay.
It takes me 2 seconds to look at the x-ray image myself.
Great. I just don't want to be annoying.
I usually try to get back to you within the day.
Cool. Yeah, you guys are great.
Yeah, but it's hard. We just like have so many requests for same day. Kids are fracturing constantly. So I'd rather take the 2 minutes than have like 30 patients on my schedule that day.
Great, thanks.
Other questions? All right. Thank you all. Yep.